Guess we'll get started. Good morning, everyone. I'm Dylan. I think I know most of you. If not, I'm Dylan. Today we're going to be talking about wound management. Most of these questions are fairly open-ended, but some of them are a little bit more specific. We'll get into that as we go. And let's get started. So, in terms of infection, there are certain chronologic factors related to wounds when they happen, when people present, that influence the infectious potential that they have down the road in our course of treatment. So for anyone, what are some factors that we might think about in terms of the chronology of wounds that affect their infectious potential that anyone might be aware of? Yep, time to presentation. Yep. So those are a couple of them. So mechanism, time to closure, those are a couple of things amongst others that affect the infectious potential. Time to presentation is the primary factor that will affect the long-term infectious potential of a wound, versus time to closure has a much smaller effect on the infectious potential of a wound. So if someone is sitting around with a wound for a week or two, that's going to have a much bigger influence on the infectious potential than when we actually close the wound. Other already present factors, such as someone's medical history, diabetes, peripheral vascular disease, immunosuppression, these are all things that can decrease our immune response, decrease circulation, et cetera. Other things such as mechanism of the wound for a crush injury, these we know cause a decrease in the circulation surrounding a wound, which will also affect healing. Location on the body, certain areas, the feet, the groin, we know these have more bacteria than other areas of the skin, as well as the degree of initial contamination. If someone's covered in dirt, they're probably a bit more at risk than if it happens in a clean OR or something like that. Next one. Felt like something came up and bit me, which is from a movie. Hopefully we all know. What is our approach to mammalian bites, specifically canine or human bites? What are some big words that pop into our heads for this? What kind? Yeah, that's a good one. Good place to start. So the standard antibiotics, and in some cases antiviral treatments, we'll talk about a little bit when we're thinking of mammalian bites. Augmentin is really king for most mammalian bites, human bites as well as canine. If there is no Augmentin in supply, Keflex can also be used. It is effective. Not often, but sometimes we will see patients with bite wounds from another person who has herpetic whitlow. For those, acyclovir can also be used as an antiviral agent. This is more for symptomatic treatment. Unless the wound is a gaping wound on the face, that implies a little bit more of a cosmetic ramification, but for most bite wounds, we're going to leave these open because there is a high risk for infection. Another thing that we will also see quite a bit in the ED is someone who comes in from a bar fight, something like that. They have cuts over the knuckles from someone else's teeth. That still counts as a bite wound, even though it isn't per se a bite. And we're going to treat it exactly the same way. Good clean out, antibiotics. And unless we have it on file or otherwise, we're going to give tetanus. And in some cases, this is moving back to animals, obviously, rabies prophylaxis. Doxycycline, Cipro can also be used if someone is severely allergic to penicillin and they can't receive Augmentin. And those are some of the standard treatments for that. So this one is near and dear to us living in New York. When we're thinking about rodent bites or rat bite, actually had a patient who came in for something like this a little while ago. She was fine. What do we think about when we're thinking of rodent bites, specifically this guy right here? Yes. Besides rat bite, anything else? Yeah, those are two good ones. Rat bite fever, rabies. So for rat bites, rodent bites, they can inoculate fun bacteria called streptobacillus or even spirillum. This can, in some cases, it's not the most common, but cause rat bite fever. The manifestations of rat bite fever are usually a little bit delayed in onset. The incubation period is around a week. Patients will come in with rigors, fever, morbilliform rash, polyarthralgia, which can oftentimes not really be very specific. So you have to take a good history, trace it back, and see if they had some unfortunate rodent interaction. For someone who actually does have rat bite fever, we don't want to hesitate on antibiotics, penicillin, doxy. These can be used because the long-term effects of rat bite fever often affect cardiac tissue and renal tissue as well. So that is something that we must treat. And like many of the other things that we've been talking about today, augmentin, making sure someone is up to date on their tetanus is also very important.
And you don't have to give, for small rodents and lagomorphs, you don't have to give rabies. They don't really transmit it.
Right. Yeah. All right. Here we go. Another one that we are all very familiar with, needle stick injuries. Unfortunately, they do happen in our field of work. When we are thinking about needle stick injuries from a contaminated needle or suture needle, what are the diseases we think about? And when you guys think about transmission rates, are there any particular diseases that jump into your mind that are higher or lower on the transmission rate? What are some common ones? Yeah, for sure. Yeah. So the transmissibility of these, usually in this case, viral infections that we're talking about, is not the sole thing that we think about when we're using post-exposure prophylaxis. Hep B is one of the higher transmission rates. It's usually somewhere around 37 to 62% in a patient who is antigen positive for Hep B. Hepatitis C is much lower. That's usually a 2% transmission rate. And then HIV is the lowest at 0.3 transmission rate. The PEP that we use is more based on the long-term ramifications of if a healthcare worker in this case is actually infected with one of these viruses due to the health concerns. So HIV, there are different regimens that we use. It's usually a triple drug regimen. The bictegravir, metronidazole, and tenofovir, that's the usual one that we use. Raltegravir and dolutegravir combined with another or two other antivirals is another one. This varies on where you are in the country. And then for Hep B, I won't get into a long discussion on the treatment for it. There's a very good chart on UpToDate. It's mainly based on the infectivity of the let's say the patient who provided the contaminated blood. So depending on the immunoglobulin status, or I'm sorry, if it's an active infection in the patient, that will determine whether we give the vaccine or the immunoglobulin or both to the person exposed. All right, foreign bodies, another fun one. So, oh, yes.
But sometimes patients have like so much anxiety after having like a needle stick injury. So what is kind of like your spiel that you give them? Like, what do you say?
Absolutely. So for if you are exposed, you have a needle stick injury, that's obviously very concerning. The first things first, besides the physical thing, cleaning it out, let your chief know, let your attending know. You will, ultimately have to report it and go through the whole process of getting things, sometimes PEP, sometimes not. It's good to talk about with other people. It is a concerning and stressful event if it does involve you, but you have the resources here where any questions you have, any treatment you need, can be provided to you. So I think just talking about it with whoever you're on with, nursing staff as well can be helpful. I think that answered.
That's fine, you can turn to your patient.
Oh, yeah. Okay. All right. Back to the gory stuff. So foreign bodies. Oh, another question. Dr. Hagen.
Statement, for needle stick injuries, if anyone does get stuck, there is a hotline. I'm not sure if it's just for HIV or for everything, probably for everything, but it's on the internet, you can look up the number and get connected with the professional that really deals with these, they kind of walk you through transmission rates, what the next steps are, and help you make a decision if you want to fix something. So I use that very
Yeah, plenty of resources available. Okay. So we see foreign bodies a lot. When there are multiple foreign bodies, it's not just a stuck earring or a splinter. When there's multiple, what should one of our first thoughts or first approaches be to evaluating someone who we are very suspicious for multiple foreign bodies? Just the basics. What would you like to do? Imaging. Yeah, you want to see what's going on in there. So imaging and safe closure are the cornerstones of this. Before we provide any treatment or resolution for these foreign bodies, the appropriate imaging should be obtained. This we'll get into a little bit later in terms of modality, but imaging is the first step. Once the foreign bodies are removed, then you want a repeat image. The initial imaging can show you where things are, display of things, if it's near any important structures, and this is assuming that the foreign bodies are removed. We want to re-image afterwards to see, did we actually get everything or everything we were concerned about out of the tissue? So re-imaging is important. If there is not a high concern for vascular compromise, severe lack of blood flow or infection, usually these wounds will be closed. Obviously, there is some variance to this, but in most cases, we're going to close these afterwards, but the imaging has to happen first. Also foreign bodies. Like I mentioned, we see metallic objects a good amount, large chunks of wood, other things like that. But when we have non-metallic objects, let's say maybe something softer like a plastic or wood, and we're not using our, I don't want to make it too obvious, we're not using our maybe first step in imaging. How do we look at these objects? Oh, that was quick. I like it. All right, Sano to the rescue. So you call Team Sano, say, hey, get over here. We got some foreign bodies. CT and X-ray are great for larger bodies, more dense foreign bodies, and metallic, obviously, even a large bone, if that is the case. Sano can often be used for these smaller ones that have lower density to them. Like I said, wood or something along those lines. The hertz that we use, the frequency of our Sano, is a factor and a tool that we can use in two senses to evaluate these softer foreign bodies. When we use a higher frequency on Sano, that will give us essentially a higher sensitivity to actually picking out these foreign bodies in the tissue. The drawback of that, flashing back to physics whenever we all took it, is that it has less soft tissue penetration, the actual Sano waves. The lower frequency will dive down deeper into the tissue, but have less the fine detail that we have with the higher hertz. This obviously is not the case for everyone, but if we have a Sano machine available with a high hertz and a low hertz option, it's actually recommended to use both, to use the high hertz first and the low hertz second, so you can be sensitive and also get a bigger look into the deeper tissue. It's recommended for more of a detailed view. All right, suture choice. So this is oh, yes.
If you actually put a irregular surface, for example, you have a lot of the winters are irregular, then like the preparation of your teaching, like for example, they can do a water bath, and you can use that water bath as a kind of
like a yeah. Yeah, another good technique. All right. So suture choice. this is something that I personally have over the years have heard different things about, but when we have someone coming in for, let's say, a facial laceration, in terms of our suture choice, our suture material, what's everyone going to jump to first? What do you want to use for a facial lac? I'm hard of hearing. Speak up. Okay, getting some soft answers. There's an old teaching that has been very much disproved, but I'm sure many of us have heard it, myself included, that we want to use non-absorbable on the face for better cosmetic effects. This is false. Has been disproven. It's debunked. So we want to use ideally rapid absorbing sutures, even on the face. There is no change in the cosmetic effect or the outcome. But it's something to be mindful of because, again, we are questionably have been told this over the years. Absorbable sutures have no inferiority. The healing outcome is very well. And even in something that has potentially a higher, needs a higher tensile strength suture, they are still more than adequate to repair. They can keep their tensile strength, the absorbables that is, for up to 60 days. Usually, hopefully, they're not going to be in there for 60 days anyway. They will dissolve, but just for our learning purposes. Grossly open wounds, these might take a little bit more doing. Maybe we'll consult OMF, but the main point of this slide is just to remember that we don't have to use non-absorbable for the face.
It's very important. Little kids were taking out the sutures was really difficult sometimes.
Right.
Had that problem.
Right.
And make more of a mess than putting them in.
Right. Another
In
bonus.
addition, especially in people you can't trust to come back, if you have a undomiciled guy who's maybe alcoholic and stuff, and you know in your heart of heart he's not going to come back to take the sutures out. And I've seen those kind of patients come back 3 months later and still have the sutures in. So
Right.
then it's a good idea, especially to use absorbable in those people.
Better for everyone.
Ideally, it should be Vico-Rep-E, not regular Vico, because that's station.
Yeah, the rapid dissolving.
What's your thoughts about that, like, so in terms of like the polyfilament and monofilament? I prefer if I'm gonna do like skin to do monofilament than
I
polyfilament.
think monofilament is better, Steve.
Yeah, so that was the point I was gonna make, like not all absorbable sutures are equal. So my goal is polyfilament, and the idea for that is that if you're using the subcu or vascular, where it really comes, is that the multiple filaments allow it to expand. But if you're doing it on the skin, it also allows multiple areas for kind of nice infection to occur. So I would go, if you're gonna do absorbable on the skin, do monofilament. So that would be fast absorbing gut or like a monocryl. You can open up within the box. It has like instructions and data, and it'll tell you how long it lasts. The fast absorbing gut is like 5 to 7 days, which is really what we want. Monocryl is going to be a little bit longer, but I think that's acceptable because the fast absorbing gut can give some people reactions. And I think when you discharge these patients, you should always tell them when you expect it to absorb, and if it doesn't absorb within that time, they still should come back, and then the wound can be assessed or they can be taken out. But I actually, if you're going to use Vicol, repeat definitely, but I actually wouldn't use Vicol in the skin.
The regular Vico is like almost 4 weeks.
Yeah, which is great for subQ.
Yeah.
Put together, it gives you a good foundation of the wound and allows better healing.
It just allows for epithelialization of the tract, so you get those dots on the side of it.
All right. All right, we'll go a bit quicker through the end. So foreign bodies near a joint. I'll get right into the kind of answers for this. So the main thing that we want to remember if we have a foreign body near a joint is to keep the joint straight. We don't want to really be ranging the joint around too much. There are a lot of important structures in the joint, the bursa, neurovascular tissues. So when we have someone coming in with a mechanical fall, let's say in a parking lot, they have some gravel in their knee, something along those lines. This should set off a little alarm that lets us know, hey, this is near a joint. Let's be careful about this. Immobilization with a splint or whatever we have on hand to keep the joint more immobile, at least temporarily while this patient is being evaluated, is very important. The long term of objects migrating into the joint, that can be figured out down the road. But in the ED, our job initially is to evaluate these wounds, but we don't want to cause more damage than there already was because we're manipulating the joint too much. That is that slide. High pressure injuries. So this is an interesting one. The picture is, I think, fairly informative about this. But when we have someone, let's say, who is using an EpiPen improperly, and we have a high pressure digital injury, what are some factors that jump into mind? I'll help us out. So pressure injuries to the digits, EpiPen, industrial machinery, grease guns, something like that can be dangerous for the fingers with high pressure. It's a very closed small space. Usually, if we have a laceration or something along those lines, we'll do a digital block. In this case, we're not going to do that. Even though it's slight, any further pressure that we add to this closed space can worsen the injury and the tissue damage. If we have someone with the EpiPen, even if there's epinephrine involved, we can still just observe this patient. In some cases, we'll use nitrates, warm water, phentolamine, and not often, but sometimes. But for the most part, even if it's with epinephrine, we can still just watch this patient and watch for tissue changes, color change. Every now and then, we'll consult hand, especially if it's more of a dirty high pressure injury. This is more along the lines of industrial origin. Any questions about this one? Yes.
I would just say my practice would be any high pressure injection injury, I would get hand and I would transfer to a place that has it.
Yeah.
If I don't have it. It's gonna present not looking that bad, and you should have just a high expectation that it's gonna get much worse, and then might get more out of that.
Yeah. All right. Last one. Primary versus secondary versus tertiary. These are all different closing techniques. I'm just gonna jump through the indications for these. So primary closure, this is probably what we're most familiar with, especially in an ED setting. This is closing the wound more or less at the time of initial injury, best for rapid healing time and bleeding control. So that's twofold. Secondary intention, this is going to be more for known contaminated wounds, a visibly or blatantly dirty wound that is intentionally left open. This is often done by our surgical colleagues, depending on where it is. And this has a much poorer cosmetic effect, but if there is high concern for infection, this is the modality of choice. And then lastly, tertiary intention or healing by tertiary intention. This is for questionably contaminated wounds where maybe it isn't quite as blatant, where we'd like to do secondary intention, but not where we're comfortable enough for primary. This will have the wound partially covered, obviously after cleaning, observed for 4 to 5 days, and then reassess after that and potentially close, and in some cases, further debridement or cleaning. And that is about it. Thank you, everyone.